The subcommittee will come to order. Welcome to the Ways and Means Health Subcommittee hearing on the current status of and quality in the Medicare Advantage program. I'm honored to welcome our four witnesses today as we continue our discussion on improvements to the Medicare program and turn our focus to Medicare Advantage, where nearly 40% of seniors with Parts A and B coverage are choosing to enroll. The Medicare trustees continue to project more seniors will choose Medicare Advantage plans in the coming years. These statistics highlight the popularity of the Medicare Advantage program, demonstrating that seniors prefer the choice the program continues to provide. By expanding competition in the Medicare program, Medicare Advantage has proven that choice and competition work in keeping health care costs low for seniors and to improve care. Today we'll hear from our panel of witnesses of what Medicare Advantage plans are doing well and how the government can get out of the way to spur more plan competition and better health care outcomes in our Medicare population. The hearing will also give us an opportunity to examine the existing quality measurement system in the Medicare Advantage program. And finally, we'll learn about consumer interactions with Medicare Plan Finder and how this beneficiary tool may be improved to keep up with our technology-savvy seniors. As the Medicare Advantage program continues to grow in size, we must ensure that it's able to grow with technological advances and the evolving healthcare delivery techniques that we've come to expect. The Medicare Advantage program has come a long way and can be used as a testing ground for many healthcare innovations that are unavailable in traditional Medicare. How we incentivize innovation that leads to better healthcare quality, access, and outcomes is vital. While the star rating system has the ability to help drive these changes, effective measurement is the first step. And I appreciate the solution-based testimonies of the witnesses here today, and this subcommittee looks forward to fleshing out the details of their proposals throughout this hearing. Now, I'm pleased to recognize my friend and colleague, the distinguished member from Michigan, the ranking member, Mr. Levin, for the purposes of an opening statement.
Thank you, Mr. Chairman, and for this hearing, and thank you to our witnesses for joining us this morning. The Medicare Advantage program is based on the promise of choice for seniors, and beneficiaries today enjoy more choices than ever before. Those who prefer care without restrictions on doctors and hospitals can enroll in the traditional Medicare program, while those who prefer a managed care alternative have the option to enroll in Medicare Advantage. Reforms made by the Affordable Care Act have improved quality and reduced overpayments in Medicare Advantage, while still providing 99% of seniors access to a plan. For the promise of choice to be a meaningful one, Medicare beneficiaries must be given complete and accurate information. A 2017 Kaiser Family Foundation study found that 35% of Medicare Advantage enrollees are in plans with narrow provider networks. Additionally, in many states, beneficiaries with pre-existing conditions who wish to switch back to traditional Medicare can be subjected to discrimination and underwriting in the private Medigap market. These and other trade-offs are not adequately conveyed to beneficiaries on the current Medicare Plan Finder website. It is also crucial that we acknowledge and respect the choice of the 2/3 of beneficiaries who are enrolled in traditional Medicare by addressing counterproductive limitations in the program. For example, committee Democrats have introduced legislation to provide all seniors with comprehensive dental, vision, and hearing coverage. Denying coverage for these essential services not only hurts beneficiaries, but can also lead to greater expenses when untreated conditions lead to complications. I would further draw the Chairman's attention to an area of bipartisan agreement regarding Medicare choices. At a September 2017 markup, Chairman Brady affirmed his commitment to ensuring parity in telehealth benefits between traditional Medicare and Medicare Advantage. We are still waiting to see action on that commitment. Recent expansions of supplemental benefits in Medicare Advantage further underscore the need to provide parity to all seniors. We would also be remiss if we failed to discuss recent regulatory actions by the Trump administration that could undermine choice and increase confusion for Medicare beneficiaries under the guise of promoting flexibility. Weakening of plan design rules in the 2019 call letter could allow plans to cherry pick and discriminate against sicker beneficiaries. CMS has also signaled an intent to roll back consumer protections in the Medicare marketing guidelines without providing a draft for public comment. Finally, as we discuss choices for Medicare beneficiaries, let us remember the very difficult choices so many have in finding a way to pay for the prescription medicines. President Trump has been promising to lower these costs, a pledge we will likely hear again this week, but there has been a painful lack of action on this issue. Democrats have put forward and stand ready to act on real reforms, including allowing Medicare to directly negotiate prices in Part D with drug manufacturers. Mr. Chairman, I urge you to call a hearing in the near future on addressing the high cost of prescription drugs. Once again, I'd like to thank the witnesses for joining us this morning, and we all look forward to a constructive conversation. Thank you, Mr. Chairman.
Thank you, Mr. Levin. Now let's turn to our witnesses. First, we'll hear from Caroline Mortensen, Associate Professor at the University of Miami. Well, she'll discuss research surrounding quality measurement and how data can be refined to improve information used by policymakers, plans, and consumers. Then we'll hear from Andrew Toy, Chief Technology Officer at Clover Health, an emerging healthcare startup focused exclusively on Medicare Advantage, and he will discuss the data-driven model developed by Clover Health to best serve Medicare beneficiaries and the challenges faced by new entrants in the Medicare Advantage program. Now I'd like to yield to my friend from Butler, Pennsylvania, to introduce our third witness, Mr. Kelly.
Thank you, Chairman. It's my pleasure to introduce Ms. Daphne Klausner. And we just talked briefly. She's from Philadelphia, and I was congratulating her on her Super Bowl win and told her how sorry we were in Pittsburgh that we let the Stanley Cup get away from Pennsylvania this year. But Ms. Klausner is the Senior Vice President of Senior Markets at the Independence Blue Cross. She provides overall leadership to Independence's Medicare business, encompassing operations, sales, and marketing, risk analysis, and performance management areas, which also includes oversight of the Medicare Star Rating initiatives. Independence Blue Cross is one of the largest health insurers in Pennsylvania and serves over 8.5 million people in 24 states. In Medicare Advantage, they cover over 100,000 beneficiaries. Also, Ms. Klausner, as you know, the district that I represent, over half of the people I represent take advantage of Medicare. So we have to make sure that we're doing the right things for the right reasons. So thank you so much for being here today and taking time out of your busy schedule to be with us. We appreciate it.
And then we'll hear from Jack Hoadley, a researcher from the Health Policy Institute at Georgetown University. He's here to discuss the findings of a recent report from the National Council on Aging and the Clear Choices campaign on modernizing Medicare Pathfinder to improve consumers' Medicare shopping experience. So, Ms. Mortensen, you're recognized for 5 minutes.
Thank you. Chairman Roscom, Ranking Member Levin, and distinguished members of the Subcommittee on Health, thank you for the opportunity to appear today to discuss quality ratings in the Medicare Advantage plan. I'm an Associate Professor of Health Sector Management and Policy at the University of Miami in Florida, where I teach and conduct research on the delivery, financing, and organization of the healthcare system. Some of my research does look at outcome measures in managed care programs that are publicly funded or federally funded. I earned my PhD in Health Services Organization and Policy at the University of Michigan. The first thing you learn as a student at the University of Michigan studying healthcare is the Donabedian framework for measuring quality of healthcare. So the Donabedian framework assesses structure of healthcare, processes in healthcare, as well as outcomes in healthcare. You see other metrics as well, like patient experience and access measures. Most of the measures you see, particularly in the Medicare Star Quality Rating rankings, are process measures. And there are a number of reasons why process measures are included. They're the easiest measures to measure, easiest metrics to measure, in that they tend to be in adherence to clinical guidelines. And perhaps most importantly, they're the metrics that physicians have the most direct control over delivering those processes. So processes could include whether or not a physician conducted an eye exam or a foot exam on a diabetic patient. Now, what those process measures don't capture, though, is what happens to that patient once they go home. Do they develop blindness related to that diabetes or not? So those would be outcomes measures, which members of the subcommittee are concerned about and would like to see more outcomes measures in the Medicare Advantage plans, as would a lot of the plans would like to see these measures as well. So what do outcomes measures mean? They mean once you've done these processes and encouraged a good structure of a healthcare system, how do you ensure that the individual's health or the population health is actually improving? So we're pushing today to talk more about incorporating more of these outcomes measures. Outcomes measures provide insight into the quality of care provided, but one downside is they can be influenced by factors that happen outside of the healthcare system, like patient compliance or issues with social determinants of health. When you look at quality as defined by the former Institute of Medicine, the word outcomes is actually in the definition of quality, where quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So specifically looking at the Medicare Star ratings, those are designed to reflect quality of care delivered both for the beneficiaries so they can make an informed plan choice and look for a 4- or a 5-star plan, but they're also used post-Affordable Care Act for reimbursements at a higher level, incentive payments for these plans. So plans are paying a lot of attention to these metrics and could be incentivized to focus more so on, particularly if they're outcomes-oriented metrics. Medicare reimburses these plans, the private plans, on a risk-adjusted per capita payment as opposed to traditional fee-for-service Medicare. So we focus on these quality rankings, and the rankings include outcomes, intermediate outcomes, patient experience, access, and process. But of the about 45 metrics, only 3 of these metrics are actually outcomes-based. So what are those metrics? Those metrics include all-cause readmission rates, which are important for Medicare in general to focus on, but they also include maintenance and improvement in self-reported physical health and self-reported mental health. So there are a lot of potential opportunities to include other outcomes measures into these metrics. Now, I want to be careful. One of the issues we struggle with in healthcare is what we call now measurement cacophony, where we have so many measures. I'm not encouraging that we add on additional measures. I'm suggesting perhaps we focus on how many process measures we have, whether some of those could be removed. The Medicare Advantage plans already have more measures than any of the other value-based plans in Medicare, so perhaps you could remove some of these process metrics and focus on measures that are more outcomes-based and are perhaps more clinically meaningful, and also perhaps relate back to the health services area, a geographic area where the beneficiary resides. So a lot of these metrics are happening at a contract level, which can span across, as you mentioned before, 4 different states. So it would be important for the beneficiaries to see what are some of the metrics happening in their zip code or in their geographic area. So I appreciate that there's attention and focus on this matter, and I thank you for your time.
Thank you. Mr. Toy?
Chairman Ruscombe, Ranking Member 11, and distinguished members of the committee. Thank you for providing Clover Health the opportunity to share our views on the Medicare Advantage program. I'm Andrew Toy, the Chief Technology Officer for Clover Health. I oversee engineering and drive the vision for how technology can improve the lives of Clover's enrollees. I received my bachelor's and master's in computer science from Stanford University, and prior to Clover, I worked in Google's Enterprise Cloud division. Clover Health began offering MA plans in 2013 and has grown to over 30,000 enrollees in several states. Our core business model is designed to rapidly generate new care delivery approaches and statistically measure their real-world effectiveness. My testimony today will touch 4 key areas. First, using data and technology to deliver high-quality care. Innovation in health improvement begins when we are able to drive enrollee engagement and promote healthy behaviors. Insurers should be developing approaches to managing patient care rather than managing financial risk through pricing and utilization controls. Clover believes that the MA program, combined with the application of data and technology, can uniquely deliver on the promise of increased value to Medicare enrollees. Our platform has the ability to compile data from varied sources, such as claims, electronic health records, and genomics, and weave them together to provide a much more comprehensive health profile. Clover can then apply our machine learning capabilities to extract key insights, such as predicting whether an enrollee is at a higher risk for admission to the hospital. Generating insights from the health data of our enrollees is only useful if we're also able to affect their health outcomes. Clover is developing intervention protocols that do just this. For example, Clover has developed protocols that identify chronically ill patients and provide them with at-home care. Another example, today a large number of hospital admissions are due to adverse drug events. To reduce these risks, Clover will offer genomic testing to personalize each enrollee's drug regimen at no cost to the patient. We believe these three capabilities, compiling data, monitoring, and proactive intervention, have the potential to significantly improve enrollee health outcomes. My second point today is on increasing competition and lowering barriers to entry. Even with the growth of MA plans over the last decade, there are still significant opportunities for future expansion and growth. Clover has a unique perspective on barriers to entering the MA market and factors that inhibit market competition. Unlike startups in other industries, CMS's network adequacy regulations prevent us from providing our product overnight nationwide. Satisfying adequacy standards may be useful to measure access in closed network models, but they are not a consequential measure of access in open, preferred provider organization plans. As a PPO, Clover allows our enrollees to choose any provider who accepts our enrollees and original Medicare. Permitting flexibility to CMS's existing network adequacy regime will encourage greater market competition and more new entrants in MA markets across the country. CMS's requirement that plans maintain an adequate network of providers, specialists, and hospitals based on outdated time and distance standards may impede competition and growth, particularly in areas where providers and hospital systems have consolidated their market share. Thus, we urge policymakers to focus on access and choice when evaluating network adequacy. My third point is empowering patients with access to their personal health records. Clover applauds the recent focus and efforts to empower enrollees with control of their healthcare information. Creating a patient-centered model will allow enrollees to make much more informed decisions about their health. We support the committee's efforts to allow enrollees to own, direct, and disclose their health data to whomever they choose, such as to a new provider, health plan, or health app. Finally, we support recent policy changes that facilitate innovation and better health outcomes by allowing plan flexibility in supplemental benefits and telehealth, as well as changes to the risk adjustment program. Thank you again for providing Clover Health with this opportunity, and it's an honor to be here with you today, and I look forward to your questions.
Thank you. Ms. Klausner?
Chairman Roscom, Ranking Member Levin, and members of the subcommittee, good morning, and thank you for the invitation to testify at today's hearing. My name is Daphne Klausner, and I'm the Senior Vice President for Senior Markets at Independence Blue Cross in Philadelphia. Through our parent organization, Independence Health Group, we serve over 8 million people in 24 states and the District of Columbia.
Ms. Klausner, could you pull the mic just a little closer?
Yes, I'm sorry. Is that better? We are the leading Medicare Advantage plan in Southeast Pennsylvania, where we've served the community for nearly 80 years. Our 100,000 plus Medicare Advantage members live in a diverse region that includes the poorest large city in America, as well as several academic medical centers. High demand for Medicare Advantage has prompted unprecedented competition in certain markets, including Philadelphia, where 14 insurers offer products in 2018. We welcome competition, and we responded by offering a zero-premium product with additional benefits not found in traditional Medicare, such as hearing aid coverage, fitness benefits, and a 24/7 nursing hotline, all while our members are protected by limits on their out-of-pocket costs. Affordability, added benefits, and greater care coordination are driving the program's popularity nationwide. Medicare Advantage plans provide better quality and lead to better health outcomes. These successes are based on recent legislative reforms that came from this committee, as well as many of the regulatory changes CMS made for 2019. Together, these policies show the federal government's commitment to affordability, innovation, and flexibility. As an example of innovation, at the direction of Congress, CMS is now encouraging the expansion of telemedicine platforms. This will give people access to on-demand care at home or while traveling. On April 19th, Independence announced a new partnership with Comcast to develop a patient-centered portal that includes telemedicine services and other digital health features that will connect patients, doctors, and caregivers. An example of flexibility, policy changes from Congress and CMS will allow plans to offer additional supplemental benefits and reduce cost sharing to our most vulnerable members with chronic conditions. These changes will allow plans to work more closely with the provider community and local organizations. At Independence, our goal is to use innovative plan designs to focus more heavily on the social determinants of health that impact our members. For example, Independence is exploring a nutrition benefit for newly discharged hospital patients, since shopping for groceries and cooking might be impossible for a senior recovering from a hospital stay. In addition, an estimated 3.6 million Americans forego medical care because they lack access to transportation. Plan design flexibility will allow us to better address individual patient needs. We are also pleased that CMS, Congress, and other key stakeholders are committed to improving the encounter data system. Although the system is improving, CMS and Congress should curtail the use of this data for payment purposes until processing times improve and plans have more clarity on how submissions are adjudicated. Furthermore, Independence agrees that the value-based intent of the STAR rating system, which ties reimbursement to measurable performance on over 40 clinical and patient experience metrics, has been responsible for a profound reorganization in how plans operate. But the program needs reforms to make the scoring process more reflective of true quality to help beneficiaries interpret meaningful differences between plans. We encourage CMS to continue focusing on STAR measures that push plans and providers to collaborate on improving patient health outcomes. In closing, we strongly support the policy changes Congress and CMS have made to grant plans like ours more flexibility to address social inequities in health and provide coordinated care in a more holistic way. We agree with the efforts to accelerate the transition to value-based payment as we move away from a volume-based system. On behalf of Independence Blue Cross and our CEO, Dan Hilferty, I'd like to thank the members of this committee for the opportunity to share my thoughts with you today. We are excited to be a part of this important discussion and look forward to working with you to ensure the continued success of the Medicare Advantage program. Thank you.
Thank you. Mr. Hoadley.
Thank you, Mr. Roscom, Mr. Levin, and members of the subcommittee. I'm Jack Hoadley, a research professor at Georgetown University, and I appear today both as a Medicare researcher and a Medicare beneficiary. I also recently completed 6 years on the Medicare Payment Advisory Commission, MedPAC. I do not speak on behalf of Georgetown or MedPAC, but only for myself. I appreciate the opportunity to share my perspectives about Medicare Advantage and the Medicare Plan Finder. Medicare is a critical element of our nation's social insurance framework because Medicare provides health coverage to nearly 60 million beneficiaries with diverse backgrounds, situations, and needs. It's a significant challenge to educate beneficiaries about the program in general and about Medicare Advantage plan options. Notably, it is time to make improvements to the online Medicare Plan Finder, a valuable tool that needs significant modernization to do that job better. All of us who are Medicare beneficiaries need to be well informed about our options. If we do not know key insurance terms like deductibles or coinsurance, if we do not understand the various parts of Medicare or the rules around supplemental insurance such as Medigap, if we do not learn about the benefits and provider networks for different MA plan options, then we are at risk. Misunderstandings about how Medicare works can lead to costly decisions. Research tells us that Medicare beneficiaries tend to purchase more protection than they need and focus more on plan premiums than on total costs. Also, while consumers value choice in purchasing insurance, too many choices can lead to information overload and missed opportunities to save money or switch to plans that would serve their needs better. The Medicare Plan Finder has been a neutral and unbiased resource for beneficiaries for over a decade, helping us make choices about the program. Yet a new report the chairman mentioned, Modernizing Medicare Plan Finder, recently released by the Clear Choices campaign and the National Council on Aging, recommends that the program must be improved and modernized to incorporate the best e-commerce practices. This report drew upon interviews with beneficiaries as they navigated the Plan Finder, a survey of directors of state health insurance assistance programs, or SHIPs, and a review of all online Plan Finder functions. The report found that today the Plan Finder is overwhelming and information is poorly presented. This leaves beneficiaries confused and can contribute to poor decision-making. Let me elaborate. First, modernizing the Plan Finder requires redesigning it to make the layout more user-friendly and more intuitive. For example, every time a user wants a definition for an insurance term, it opens a new tab on your browser. We find that some consumers end up with 20 to 30 open tabs. This is not helpful. Replacing insurance jargon with plain language is also critical, and adding a web chat function could help offer people quick and accurate answers. Second, when comparing choices among MA plans or between MA and traditional Medicare, beneficiaries want an accurate estimate of their total out-of-pocket costs, and they want that comparison to include the effect of supplemental Medigap coverage on their costs if they're in traditional Medicare, something the Plan Finder does not do today. It should also help beneficiaries understand the limitations on their ability to regain Medigap coverage if they join an MA plan and decide to leave that plan in the future. Third, if results can be personalized, they will serve consumers better. While a perfect prediction of next year's costs is, of course, impossible, incorporation of information on health status, drugs currently used, and expected use of other services could help provide people with better estimates. Fourth, a serious gap is the lack of an integrated provider directory. Today, if you request information on whether your physician or other healthcare provider is in an MA network, this requires leaving the Plan Finder to navigate the plan's website. This is a confusing extra step for people, and we found that people failed to do that or got confused when they tried to do that. The Plan Finder is better at allowing you to find out whether your drugs are on a plan formulary, and the Plan Finder needs to make that same capability for getting information about providers built into the system and to make sure that information is accurate. Fifth, star ratings play a key role. But many think that star ratings are really just user reviews like they're accustomed to for restaurants and movies. CMS needs to convene a panel of beneficiaries and stakeholders to evaluate which star ratings are important and how best to explain them. Finally, one reason the Plan Finder can be hard to use when comparing plan options is the wide variation in benefits and features used by different MA plans. I've long advocated greater standardization in both benefits plans offer and the information used to describe them. Plans should be encouraged to innovate and add new features, but variations that are not meaningful can confuse more than they help. To conclude, all of us who are Medicare beneficiaries need accurate information and the ability to compare our Medicare options. This is critical to making an optimal choice, one that saves on out-of-pocket costs and enrolls us in a high-quality Medicare option that suits our needs. Savings for Medicare beneficiaries also translate to savings to taxpayers. We have an opportunity today to invest in a modernized Plan Finder that will better serve the needs of all beneficiaries. Thank you.
Thank you. Well, let's invite our members to inquire. Mr. Johnson.
Thank you, Mr. Chairman. You know, one of the things I hear from the folks in my district is they want to have a choice in what they get their where they get their health care from. In other words, it means that folks want insurance plans that have a broad network of providers. You know, over a quarter of my constituents who are eligible for Medicare have Medicare Advantage plans, and these folks deserve to have a wide range of providers they can choose to see. Mr. Toy, you mentioned that Clover Health is having problems contracting with certain health systems and provider groups in some areas because of a lack of local competition. I understand this is driven by consolidation within the health provider industry. Can you tell me if this is something you are seeing more frequently and how it is impacting the cost and delivery of care?
Thank you for the question. This is definitely something we are seeing. As a new plan entering into a lot of markets, we have to fulfill network adequacy with CMS in order to even offer our plan. And what we see is that when we go to see provider groups, especially if they are consolidated, especially if they have a lot of market share in a particular area, they have leverage which enables them to ask very high prices or ask for very, basically to have us pay them a lot of money for them to be part of the in-network offering. This means that we either have to agree and then pay a lot and make things very expensive for the folks on the plan in that area, or we have to basically not agree and then we don't have network sufficiency as per CMS rules. So this is a very difficult situation to be in. This is often the case, like I said, when the provider has a lot of leverage in a given market, and so we are definitely seeing that.
Ms. Klossner, I'd ask you the same question. Can you respond, please?
Yes, I mean, Philadelphia is a unique market in that we have many, many providers, many academic medical centers, many hospitals, many physicians. I would say because of the history of my plan in particular, we've had a relationship with most of these providers for a long time. We've been in the business for 80 years. We have good relationships with our providers. I think that what we're seeing in our market is that our providers are being more collaborative with us, transferring to value-based payments. So we see a positive relationship between the providers in the Philadelphia market. And so unlike Mr. Toy, in which New Jersey is a little more challenging, we were in the New Jersey market for a little bit. In Philadelphia, we're not seeing exactly the same thing, but we are seeing much better collaboration between the provider community and the health plans.
And do you see that different in every state?
We operate only in the 5-county Philadelphia area, so I can't comment on that.
Okay. Thank you, Mr. Chairman.
Mr. Levin.
Thank you. Usually when we have panels, there's a lot of disagreement, or some. So I'm searching to see if there are different perspectives. Mr. Holder, you talked about the problems with the plan finder. Is there any disagreement among the four of you on his suggestions?
No, we actually agree wholeheartedly. Plan Finder should be modernized to be a little more intuitive and helpful to beneficiaries. The way it does work is very confusing.
I will also agree. And in this case, I would also point out that as we try to do more innovative things with the plans, as things tend to diverge a little bit more, as we experiment, it will be harder for something like the Plan Finder to keep up with that in its current state.
I agree as well. If, as Mr. Hoadley is saying, that these metrics are being perceived more as a Yelp review as opposed to the quality metrics that are going into it, everything I just advocated for is not having the intended effect on the end user.
Okay. Now CMS has recently allowed more flexibility in plan design. That can increase the complexity. Why don't you four discuss that for a minute? Mr. Hoadley, do you want to discuss it, and we'll go down the row quickly?
Sure, thank you. Yeah, I mean, I think the idea of adding more flexibility adds more opportunities to try innovative things, but it does potentially introduce complexities and thus confusion for beneficiaries. If beneficiaries are trying to understand there's this additional benefit in this plan, this other plan has these benefits, and the third plan has something completely different, and there's some different prices associated with those plans, it's hard to make comparisons. And I think to the extent that we can find a balance between the right amount of new ideas and ways to keep enough standardization so that we make sure that people can understand and make wise choices when they're evaluating their options.
Ms. Klausner?
I would say that the ability to be flexible with the benefits is probably one of the best things that's happened to the Medicare Advantage system since I've been in this business, which has been for 23 years working in Medicare Advantage. You know, we have, in our particular plan, we have Philadelphia, which is a large, poor city. We have surrounding suburban communities, which have a wealthier, population. The ability to have different plan offerings and benefits to address the particular needs of the different constituents in those particular areas is really important for us. You know, I talked a little bit in my testimony about social determinants of health and how important that is. To be in a large city where we have a lot of people living alone, a lot of people at the poverty level, and a lot of people who don't have, for instance, dental care, which is something that we're trying to figure out as a plan for the 2019 bid, is really important to us, and I think is also very important to a lot of different beneficiaries.
Right, we have legislation to provide within Medicare for everybody that benefit. And it would seem to me that what you say makes that wise. Mr. Choi, excuse me.
No, sorry. I think being able to offer a dental benefit to every Medicare beneficiary would be extraordinary, to be honest with you. I was just talking about a little bit having the flexibility with other benefits, depending on the particular area that a plan may be operating in. But certainly some things, like I said, dental, hearing aids is another one which there's a huge demand for. That would be really important to put in all benefit plans if it's at all possible.
Thank you.
We definitely appreciate the innovations around flexibility as well that have come out in the last few years. I think the way we see it is from a perspective of individualization and personalization of treatment and care for our population. We look at our data within the platform all the time, and what we try to see is people as individuals and to try to create the best outcomes for those individuals. And we are within that bid construct, within that plan construct right now, but what I think we believe we'll see more and more is that it's creating that individualized care, meaning is leading to individualized benefits as well. So the more flexibility we have, the better off we'll be.
Well, you have, as a graduate of U of M, 14 U of M seconds to finish my time. Thank you.
I would just add two additional things. I think it's great that there's increased flexibility and additional benefits, particularly benefits that address social determinants of health, but it would be important to make sure those are reflected in the updated quality metrics so you can see if those investments are paying off. But I would also suggest be careful of unintended consequences and make sure that these are not benefits that are just going to Medicare Advantage enrollees, and make sure that traditional fee-for-service Medicare beneficiaries are not left out of some of these comprehensive improvements.
Thank you very much. Thank you, Mr. Chair.
Mr. Smith.
Thank you, Mr. Chairman. Excuse me. Thank you to our panel as well. You've touched a lot on the star rating situation, and perhaps the star ratings give or portray something that isn't necessarily a complete picture. And a couple of weeks ago, we had a roundtable, a bipartisan gathering here. The constituent Leslie Marsh, the CEO of a critical access hospital, Lexington Regional Hospital, and she brought to our attention the impact the star rating system is having on small critical access hospitals. And so she pointed out, as you might imagine, that many perform extremely well under the star ratings. Their rural status can sometimes prevent them from actually qualifying under certain star ratings in and of themselves. So just a few numbers here. You might be familiar with the North Carolina Rural Health Research Program that found that critical access hospitals were less likely to receive a quality star rating than other types of rural hospitals. The study found critical access hospitals comprise 90% of the 762 unrated rural hospitals. And the same study concluded 43% of the not rated rural hospitals were in the Midwest census region, which certainly includes my home state of Nebraska. And as a result of not being rated, the critical access hospitals show up under the hospital star ratings website as having 0 stars. If consumers equate 0 stars with poor quality care, it's obvious how this could be a problem for many of the hospitals that actually provide superior care. So, Ms. Klausner, in your written testimony, you described the need for regional adjustment for star ratings. Can you talk a little bit about the data and research that could help us determine how to make the adjustments so that the star rating system would better account for the different operations at rural facilities while certainly still holding hospitals to the same high standards as an urban facility?
I can talk for a minute about the need for regional adjustment, certainly within the 5 counties that we operate in. Again, I referenced Philadelphia, which is a very large, poor city, and the utilization in Philadelphia County is different than some of the outlying counties. The hospitals that are in Philadelphia, the University of Pennsylvania, Jefferson Medical Center, operate differently than some of the hospitals in our rural counties. I'll defer to Dr. Mortensen, though, on the regional differences and quality, because I think she might be a little more expert in that area.
Ms. Mortensen.
Unfortunately, I'm not. So I'm living in Miami-Dade County, where 65% of our beneficiaries are in Medicare Advantage plans. So we don't have any of the rural issues in Miami-Dade. So I don't know. And I didn't realize that this was an issue. So that's a really important issue. It sort of flies in the face of some of the other issues we've seen, which are contracts like that getting bought up by 4-star or 5-star rankings, and then that star ranking tends to account for all those different plans across that contract purchase. But I don't have solutions for the specific issue you're talking about.
Okay. And anyone else wishing to comment? Mr. Hoadley.
Yeah, I could make one comment. I mean, the work when I was on MedPAC, we developed a concept of a peer grouping approach. And so while you don't necessarily want to change the star ratings for whatever the demographic category is that may have poorer performance, whether it's SES, whether it's rural, different kinds of things, comparing for the purposes of payment and other kinds of things like that to hospitals, health plans, again, whichever category we're looking at, that are within the same peer group on that particular criterion is a way to make sure that reward systems treat everybody fairly, but still identify if there's poor performance, that we're aware of it, and that continues to have the incentives for those that might be performing more poorly to improve what they're doing. So it's more of a peer group approach as opposed to actually changing the ratings based on characteristics.
All right, thank you very much. Thank you, I yield back.
Mr. Thompson.
Thank you, Mr. Chairman. Thanks to all the witnesses for being here today. And, you know, listening to your testimony, you paint a pretty nice picture of the Medicare Advantage program and the high quality of private insurance options that serve, I think, 1 in 3 seniors. I want to just point out that it's a highly regulated market, and it does, in fact, deliver a product that consumers like. And thanks to the work that we've done in improving the program over the years, it's a very popular program with members of Congress on both sides of the aisle. And I say that because I think it's important to contrast that with what's going on in the individual market. You know, it seems that every turn, this administration and the majority are doing everything they can to whack the individual market. And you don't have to look any further than the Farm Bill that's going to be up this week, where they're promoting programs that bring back junk plans that work really well until you need to use them to cover your health care costs. And it's causing problems. The cost in the individual market continues to soar. And I don't understand why we can't work together to provide the same quality of coverage in the individual market as we seem to want to do in the Medicare Advantage market, and make these plans both cover the needs of the consumers and do it at a cost that they can afford. And I've got some questions for you on the MA program, and I hope that we can learn something that perhaps we can apply later on to the individual market. So, Dr. Hoadley, I appreciate your suggestions on the improvements for the plan finder, and I think we should do everything we can to improve consumers' experience for seniors and make those plans easier to select. And one resource that you mentioned are the state health insurance assistance programs, the SHIP. But in the FY 2019 budget, the President eliminated that program. Can you tell me what kind of impact that might have on seniors?
I think the SHIP programs represent a resource that is very important to a lot of seniors, because while many people can go to an online plan finder, whether they do it themselves or whether they rely on children or grandchildren to help them do it, there's only so far that the plan finder, even if it's modernized, can go. And many people, what they really want is in-person, one-on-one kind of assistance that's only possible through something like the counselors that are provided in SHIP programs. There are other resources to provide that kind of one-on-one help in addition to SHIPs, but SHIPs have been important resource to do that. One thing I mentioned in my testimony was the potential for a web chat function that would allow sort of a small version of that kind of individual counseling. I have this specific question, can you answer it for me? But that's not going to be nearly in the in-depth, the kind of in-depth help that somebody gets when they sit down, sometimes for 2 or 3 meetings, maybe 30 minutes.
So what happens to those seniors without this program?
Without that program, they're going to, they're going to rely on family members. They're going to try to rely on the plan finder, but they're going to end up probably in some cases making poor choices that will cost them money and fail to take advantage of a very valuable MA option in their area, or determine that traditional Medicare might work better for them. So it's those choices, if they make them the wrong way, it can not only cost money, but can put them in a lower quality environment.
Thank you. And Mr. Toy, how can we ensure that a health plan's cost controls aren't hurting the patient? What steps do you take to ensure that those cost constraints are driven by clinical decisions and not something else?
That's an excellent question. We're very, very outcome-oriented, so we would never want a decision we make from a utilization perspective, a cost perspective, to affect the outcome for the member. So we always very much are centric on the outcome. That's what we study in our data patterns and our statistics. That's how we apply our decision-making as well to when we do plan design, when we do intervention design. And so while cost is a component, obviously, of any decision, it is not the primary way that we make these decisions. We always have member care first and foremost.
Thank you. And Dr. Mortenstein, what should we be doing to improve data availability, and how does that lead to better interoperability?
So just recently, Seema Verma announced that the Medicare Advantage claims data would be released to researchers. So this is the first time, the data had been collected since 2012, the first time that researchers would actually have access to these data. I think access to these data is really important because we as researchers can go through and identify some of the issues with the data, and the data can also be used to get to some of the more outcomes-oriented metrics that I was suggesting before. So for example, you could look at an inpatient visit and see if it's what we call ambulatory care sensitive. So is that a visit in the hospital that should not have happened because it could have been prevented with good outpatient care. So some of these patients should never show up in the hospital, the emergency department. With access to these data now, which we've had for Medicaid, we can now do for managed care and Medicare, we can start to assess whether or not enrollees are getting the access to care that they need.
Thank you. Ms. Jenkins.
Thank you, Mr. Chairman, and thank you all for being here today. Medicare Advantage has seen revisions and improvements over the past couple decades, from a renaming of the program back in 2003 to the most current updates in the Bipartisan Budget Act of 2018. As Congress continues to look for new ways to improve the Medicare Advantage program and health care for the American people as a whole, we really appreciate your expertise, experience, and feedback that you're sharing with us today. In the 2017 final call letter, CMS first implemented a temporary socioeconomic-like adjustment called the Categorical Adjustment Index. However, the adjustment seems to impact very few plans. In the 2019 final advance notice and call letter, CMS stated that it remains committed to the goal of finding a long-term solution to the unique challenges of serving our most vulnerable populations. There continues to be additional work in the research community on both identifying the impact of social risk factors on health outcomes and how to best address the impact on clinical quality measurement. Based on this, I have just a few questions that I'd like to ask regarding adjustments to the current star rating measures for socioeconomic status and geography. Ms. Mortensen and Ms. Klausner, are there any measures in particular that should be risk adjusted for socioeconomic status?
Of the current measures, I think there are some questions, like for instance, I think there's a measure around risk of fall, and did your physician speak with you about your risk of fall? I think that could be expanded to ask additional questions around the current living situation that the beneficiary is living in. People who are living alone might have a different answer than somebody who's living with somebody else. There are probably other measures that I don't have off the top of my head that we could use to address those social factors, and I think that would be a terrific way to begin assessing whether some of the social works that we want to do in place would have an impact on the beneficiary outcomes. There's no questions around nutrition, to be perfectly honest with you, and if you don't have food, and I'm not even just talking about healthy food, I mean food on your table, that could be a significant factor in your health outcomes. So I think there are modifications that we should look to put in place that address those factors.
Yeah, I agree with all the points that you made when you started, that it's troubling that the introduction of this adjustment had very little effect. So something like 4% of plans actually received improvements in quality when they started adjusting for socioeconomic status and chronic conditions in their patient population. Going back to existing metrics, which ones do I think that could address the socioeconomic diversity? Could be the readmission rates. So there's a lot of research done suggesting that a readmission rate should be adjusted throughout the Medicare program to address these chronic conditions and where you live, what hospital you're going to, and to where you're being discharged once you leave the hospital. I think going along with her point, something we should think about are these additional measures that we use to replace some of the existing quality measures could be more focused on looking at measures and metrics that could adjust for that. And so one suggested metric could be what Humana uses in a lot of their communities, are their healthy days metrics, or one that MedPAC has investigated, which is called a healthy days at home metric, where you can use technology to scan through the claims to see how many days in the year where the patient was not in the hospital, was not receiving home care. And so you could use metrics like that that could try to assess more sociodemographic factors.
Okay, thank you. And finally, Mr. Toy, how can the current star rating measures change to focus on and incentivize better health outcomes?
So I think that when we look at the star ratings, oftentimes they're not directly connected to the outcomes, like you say. They are a proxy towards them, but they're not ultimately measuring the final step with our members. So they are, however, really important, obviously, for us to comply with in the short term. I think one thing we can do from our perspective is really analyze the data. Like a lot of us at the table, certainly we at Clover have statistical data that actually shows correlations between lots of these things. That we can detect, for example, indications of homelessness or having a proclivity towards homelessness from the call data when people call into our call centers, the kinds of words they use, and those can be very strong signals that we can use to inform the star ratings as well, to show how we're taking care of those populations.
Thank you. I yield back.
Mr. Kind.
Thank you, Mr. Chairman. I want to thank the witnesses for your excellent testimony here today, again, giving us some hope about what's happening in the healthcare system. But Ms. Mortensen, let me start with you and just pick up where you left off with Mr. Thompson, and that was the acknowledgement of opening up the MA claims data to outside researchers. You know, this started back with the American Recovery Act during the Great Recession, where we threw a lot of money in the HIT investment or EMR investment, and I always felt it was important to do that so we can start collecting the data as far as what works, what doesn't work, and then drive that back down into the hands of the doctors and the patients alike so they can make good decisions with it. So how significant, and I think the missing piece was the MA claims data being shared to outside. How significant is it, and what do you think is going to evolve from that? What do you think will happen making that available to researchers now?
First, I want to speak to your point about the Reinvestment Act and the High-Tech Act specifically that put a lot of money into electronic medical records. And that's the sort of precautionary tale of we have to be really careful of unintended consequences. So almost every hospital now has an electronic health record system, but none of our records are interoperable and actually speak to one another. You see this within buildings, within health systems. I think it was Trinity Health
Unless you're using Epic, which has 50% market share, and
exactly.
Of course, then they're all interoperable.
So Trinity Health announced last week they're going to now use Epic across all of their sites, which you kind of already assumed that they were interoperable. So it's careful to think about what, as we prescribe things with policy, not to overprescribe and make sure that things go well. So just to be clear, although data are now available to researchers on Medicare Advantage, there are a lot of hoops to jump through in order to get those data. And so the data that are available now are through 2015, and we're in 2018. So what we can go back and say retrospectively in 2015, these were some things, good things and bad things that were happening, but we're nowhere near a real-time adoption of data, which would be incredibly helpful for researchers.
I
And
certainly encourage you and others that if there are some hurdles or unnecessary impediments to getting this out, you bring it to our attention so we can work with you and work with CMS to see what we can do to facilitate.
Absolutely. Thank you. I appreciate that. So in general, I think that as you get academics with their hands on the research, they're able to come here and inform you, here's what we can do. So for example, that ambulatory care sensitive data analysis that I do on my own work in managed care, I can use that to now inform and say, hey, this is a great outcomes measure. So although we did not see in Florida, for example, ambulatory care visits decrease, we saw a slow in the growth. So we can look for trends like that are encouraging. So access to the data is tremendously important for researchers, but also to help inform policymakers as well. So
okay, thank you. Mr. Hoadley, there was much made of the fact that under the Affordable Care Act, as part of the pay-for, that there was going to be some significant reductions in MA plan reimbursement rates. As a consequence of that now, was there any adverse impact on the enrollment of the MA plans, on the services that were being offered, on the quality outcomes that we were asking of these plans in light of those cutbacks?
Certainly there was no drop-off in enrollment in the MA plans, and I think some of the projections thought there might be. People continued to seem to want to join those plans, and the numbers have continued to increase. I think some of the other questions are still harder to answer, and part of it's the absence of the ability to look at encounter data. If we're trying to understand such things as the way a Medicare Advantage plan manages, for example, post-acute care use. Are they sending people to different sites for post-acute care than is going on in traditional Medicare? Are they managing to make less use of post-acute care? Yeah. And then what are the outcomes? We really need to be able to look at encounter data to be able to address questions like that and to really get us to the answers of whether the quality of care received is affected adversely or positively.
Let me ask you in the post-acute care world, because Chairman Brady and I have been trying to move a discussion forward on the reforms that we feel are needed in post-acute care. I think it was one of the things we missed under the ACA Act, quite frankly. Is there a lot of opportunity for reforming that for better outcomes and ultimately a better price?
There certainly are, and while I was on MedPAC, we took a fairly extensive look at the broad issue of how to pay for post-acute care and have a series of recommendations on revising the payment systems. Medicare Advantage plans, to some degree, are able to do some of those things today, but what we really need is better information on what are they doing, have they taken steps that have had positive effects, but trying to make sure that the differential payment in different sites, whether it's a nursing home or a home health or a rehab hospital, whether you get the same results when the payment systems are different and the incentives to use those different services vary. That's the thing that's keeping us from getting the improvements we'd like to see.
Yeah, thank you. Thank you, Mr. Chairman.
Mr. Marchant.
Thank you, Mr. Chairman. As I travel around my district and visit with seniors and almost every group that I have, they come up to me after the meeting, and one of the most frequent comments is, please don't do anything to take away my Medicare Advantage. So Medicare Advantage is a very vital part. I represent a largely suburban, corporate-oriented district that many of them are coming off of a corporate plan. They're coming off of a very high level of insurance. And with a lot of trepidation, they hit that 65 mark and have to begin to make those decisions. And I had to make that decision last year. And I'll have to say that as I sifted through it seemed like hundreds of letters that I got trying to keep me informed. There seemed to be very little substantive information, and that those letters from Medicare are the private vendors that were trying to get me to sign up with them about Medicare Advantage. So my district, 32% of the people that are on Medicare are on Medicare Advantage. So I'd be interested, Dr. Hoadley, to agree. I'd like to agree with you. Education is probably the #1 thing that needs to be improved in that system, so that people can blend their co-insurances, their supplemental, and blend the whole system together. Can you name some kind of a concrete program or improvement in that area that's taking place as we speak?
So I think, you're absolutely right that education is critical, and, there are a lot of tools out there to try to help people. And I think the Plan Finder that I've talked about in my testimony, is something that's been a valuable tool for more than a decade to help people understand. But it's an online tool, which 10 or 15 years ago, we were concerned that a lot of seniors, really weren't computer savvy, weren't going online to do the choices. That's gradually changing, and the new generation of folks are going to be less intimidated just by the idea of going on the computer. But what we're in a situation is that we have a Plan Finder that really represents technology of 10 or 15 years ago, and it has not been modernized and updated to reflect both the use of the tool on different platforms. So if you try to use it on a tablet or on a phone, it may not appear very well, it may not allow you to do things, but even if you go to a mainframe computer, to a laptop or a desktop computer, you're still struggling to try to get it to work and get it to provide the information. And one of the important ways it fails is trying to really allow you to compare what you get in an MA plan versus what you get in traditional Medicare, and put all of the elements, the MA combined with your supplemental insurance, whether it's from an former employer or from a Medigap plan, with what the MA plan offer. And what you really want is a good out-of-pocket cost estimate of what are my total costs going to be look like, as well as what providers I'll have access to. And right now, the tool just isn't doing that very well. And it's not going to be that hard to fix it. We know how to do those kinds of things better, but we need some investment of time and resources, and reach out to the community, to the stakeholders, to the beneficiaries, the plans, and the rest of the community to figure out the best way to do it.
Got one more question. In 2019, Part C and D in the final rule, CMS finalized its proposal to eliminate the mandatory enrollment requirement previously proposed by the Obama administration and replaced it with a policy that requires plans to reject providers and suppliers who are included on a preclusion list. Ms. Klausner, can you discuss some of the challenges the plans we're having with implementation of the previous mandatory requirements?
Yes, first we were happy that they delayed that rule and that they have since changed it. We are still awaiting policy guidance on how to implement that. But as a plan to rely on 2 different exclusion lists for providers would be operationally challenging. Historically, we've relied on 1, so the possibility that we would have 2 for different types of providers would have been quite challenging. So we're looking forward to the guidance from CMS on how to implement the new change.
Ms. Sewell.
Well, first I want to thank the witnesses for being here today. Last year, I told the committee a story about one of my constituents from Selma, Alabama, Miss Eva. Like many of our rural constituents, Miss Eva called my congressional office to see if we could help find her a ride to the pharmacy so that she could get her insulin, or to the doctor so that she could get her routine check-in for her diabetes management. Miss Eva told us that she goes to the emergency room in an ambulance several times a year for issues that could have been addressed earlier in a primary care setting if she had access to proper transportation. A dual-eligible diabetic in her 80s, Miss Eva found that the state's non-emergency medical transportation benefit through Medicaid was unreliable. Thus, she would call us for transportation needs. Ms. Eva's story is one we could tell 100 times over in this committee. Whether it's an inability to afford a copay or transportation, millions of Americans across this country forego primary health care visits and don't adhere to medication regimens because of financial constraints. I know that when I visit emergency departments across my district and talk to providers, it becomes increasingly clear that social determinants of health, such as transportation barriers or poor housing, are driving the lion's share of costs in the Medicare program. We may not be able to prevent all the chronic conditions, but it seems to me that we could do a better job of trying to control some of those costs by just being smart about it. One of the things that I think would be of great help is if we look at the models in which we have medical Uber or something like that with ride shares, where we can reimburse providers who have this kind of ride share. I know it's more difficult in rural parts of our nation, but I do think that we need to start thinking outside the box when it comes to social determinants such as transportation. And in fact, I really am passionate about this, and Mr. Meehan and I had a bill that would allow for just that kind of transportation needs for that Medicaid offered for non-emergency transportation. We now have in Medicare Advantage. It was passed in the most recent February bill, and that was great. But I think that we have to do more for that. And so I guess my first question is to you, Ms. Costner. I know that you've been in this industry for a very long time, and transportation is only one of those barriers. And so I was wondering if you could speak to other social determinants that affect the outcomes, and can we in Congress think outside the box about how we can address some of those determinants so that we have better outcomes for our MA patients?
Well, we're also very passionate about the same issues as you are at Independence. We talked about transportation, and so we applaud the flexibility that we are able to hopefully offer transportation benefits. At Independence, we're also talking with some of our providers who are also interested in the same outcomes. So we've recently talked to a provider group that will be coming into Philadelphia to address low-income seniors, and they, as part of their provider group, offer transportation. So we're really excited about that initiative. I also mentioned food. So we talk about out of the box. I think food is probably one of the most critical factors to people's health care.
Absolutely.
And again, not just healthy food, I just mean food.
Food,
right?
Agreed.
Agreed.
You know, the other issue that I found really important, I most recently, over the weekend, went to the inaugural enrollment of All of Us program for University of Alabama. Birmingham is one of the providers for precision medicine. And going to you, I really wanted to hear from you, Ms. Mortensen, about big data and getting data analysis such that we can drive better, more appropriate treatment that, you know, going away from sort of the average patient, to this one-size-fits-all, to something much more specific and much more precision. Are your thoughts about that, and also how we in Congress could do a better job of helping get that data more real-time? Because you said that it was 2015 data.
So thank you for the opportunity to speak specifically on social determinants of health, because they really do matter. So one exciting program already underway within CMS and both their Medicaid and Medicare beneficiaries is called Accountable Health Communities model. Yeah. And so what it is, from a data perspective, we love this because it's a randomized control trial. And so what you have is now it's down to 2 tracks where these are alignment tracks, essentially. So the most comprehensive track is aligning Medicare and Medicaid beneficiaries within an organization with what's called a bridge organization that says if you need food, here's a food pantry that knows you're coming and they will be ready to serve you. If you need transportation, we're connecting you with transportation. If there's something in your home that is unsafe, we have somebody who will come and help make your home safe. So this is partway through, but randomized control trial, data, evidence, this is going to show that investing in social determinants of health prevents the downstream expensive use of healthcare. So those metrics will be really, really important, and I think will make all of your jobs easier on making these kinds of
Thank you very much.
Ms. Black.
Thank you, Mr. Chairman, for holding this informative hearing. And As a registered nurse for over 45 years, I've seen firsthand the critical importance of value-based services that they play in today's healthcare system. And we all know that if Medicare is to provide a real benefit to our seniors while ensuring real efficiency for our taxpayers, it must embrace the advances in technology that are already taking place around the healthcare sector. By focusing on the high-value services essential to our patients, especially those suffering from chronic conditions, I believe that we will begin to move away from the fee-for-service care program and into a system that rewards quality, which we're already seeing. I was very excited to see two policies that I have long championed in the Medicare Advantage signed into law by President Trump earlier this year. The first one, increasing telehealth access in Medicare Act, which I co-sponsored with Mr. Thompson, and it gives plans a new flexibility to provide telemedicine benefits in Medicare Advantage, which I think is going to really move us along. And then the VBID for a Better Healthcare Act, which I sponsored with Mr. Blumenauer, that will expand the value-based insurance design model nationwide, helping seniors with chronic conditions to better afford their medications. So the MA plans that are increasingly utilizing technology to manage the cost and improve care of their high-cost beneficiaries, such as those in long-term care facilities, is a concern of mine. More recently, innovative companies are partnering with Medicare Advantage plans to address this issue, specifically using telehealth to treat in nursing homes in place instead of transferring a patient to an emergency room. We know this not only is more efficient, but it's more efficient for the patient not to have to move them out of their facility and move them via ambulance into a hospital setting. So using innovative telehealth technology like video conferencing to connect patients with more remote emergency physicians, we can reduce these expenses to hospital visits and save the patient that inconvenience as well. Mr. Toy and Ms. Klausner, you both touched on how the plans have more flexibility to offer telemedicine services to their members, which will help to increase access to care for those individuals right in their homes, which is so convenient. Mr. Toy, can you address how else can we support the MA plans in integrating that technology in a way that benefits our beneficiaries, the plans, and the taxpayers?
Absolutely, and we're a big supporter of at-home care for all the reasons that you said just now. So we have a plan focused specifically on treating folks at home, especially for chronic conditions. We also, in those exact same cases, identify those populations ahead of time and then provide them with equipment at home, such as telecommunications equipment. We provide actually a smart speaker that you can push a button and immediately get in contact with somebody if you need help at our call center, as well as being able to do your medical appointments. We also have social work available through a partnership where you can actually get social work if you need that as well at home. So all of those are, I think, really important things that we're able to provide.
Excellent. Ms. Klausner, in our rural areas, it is often challenging for plans to build those robust networks to meet the CMS's time and distance standards, particularly for certain specialties. How do you plan on using this new flexibility, and do you think that CMS should consider adjusting the network adequacy standards to take telehealth into account, particularly in these rural areas?
I think the new requirements or new legislation around telemedicine will be hugely helpful for rural areas. I mentioned our new partnership with Comcast. I have to say one of the early prototypes that I saw was really fascinating because it didn't only connect the patient with their physician, but also the caregiver. So we have beneficiaries who have children and grandchildren who live very far away, and being able to connect those caregivers to the doctors, to the patient, sort of collaboratively is really exciting, and I look forward to seeing what we do with Comcast in that space. I think, the network requirements are there for a reason, because they want to make sure that people have access, but I do appreciate Mr. Toy's position about certain areas where it is more difficult to provide those services. I think we do need to look at regional differences in how healthcare is delivered and how people utilize healthcare, depending if it's an urban or a rural environment. So I do encourage this committee and CMS to look at the changes and look at specifically how healthcare is delivered in different parts of the country.
Thank you, Mr. Chairman. I yield back.
Ms. Chu.
Dr. Hoadley, thank you for sharing the beneficiary perspective as we discuss ways to improve the Medicare Advantage program. One thing I often hear from my constituents is how burdensome the costs of prescription drugs are for them. The costs continue to rise. A study from AARP noted that 97% of widely used brand name drugs have seen a price increase exceeding inflation in 2015. And already the cost to Medicare is significant, as 19% of the total Medicare budget is spent on prescription drugs. But for patients, all they see is the price at the pharmacy counter, and it keeps going up. So when they are selecting a plan, they want to know what option will result in the least out-of-pocket costs at the end of the day. Dr. Hoadley, you described the problems with the Medicare Plan Finder, but what can we do to make sure that beneficiaries can anticipate their out-of-pocket costs, particularly as it pertains to prescription drugs? Are there any steps we could take to improve the Plan Finder's ability to show patients what they are going to be expected to pay in the end?
So the Plan Finder does have the functionality that says, you put in the names of the different drugs you're taking. You determine, for the particular plans you're looking at, whether those drugs are on the plan's formulary, so whether you're going to be paying completely out of pocket or whether you're going to be paying only a copay or a coinsurance for that drug, and tries to estimate the potential cost sharing for that drug. Now, there are complexities that need to get improved to make that work better. For example, in many cases, the price is going to vary according to which pharmacy you're using. So, if you're committed to one pharmacy that's your go-to place, you can designate that pharmacy on the Plan Finder, and you'll get prices that are based on using that pharmacy. But if you're a person who's willing to switch to a different pharmacy in order to save money, that's hard to figure out. I actually went through it for myself and for our family, trying to figure out whether there were opportunities to pick a different pharmacy and to end up with a better cost. I eventually figured out that that was the case, but even for somebody who's studied the Medicare Part D program for as long as it's been around, I had trouble figuring out how to do that. There are also issues sometimes when people see a particular price on the Plan Finder when they're shopping for a plan during the open enrollment season, say in November, and then they go and try to pick up a drug in February, once they're actually enrolled in that plan, the price ends up being different. Now, there are a lot of reasons that happens. The manufacturer may have raised the price, but these discrepancies are very frustrating to people, and it would be really useful to have a better sense of why those happen, and then figure out if there's some way to make sure that prices can be locked in so you're not going to see changes from the time you shop for a plan until you're actually going and buying the drugs.
Thank you for that. Mr. Toy, Ms. Klausner, as a psychologist by training, I'm particularly interested in the way that Medicare Advantage can assist in the integration of mental health services in the healthcare space. We know that when someone is depressed or lonely, they can take longer to heal. And in fact, studies from numerous universities have demonstrated that loneliness has measurable negative impacts on patient health. That's why I'm proud that CareMore, a Medicare Advantage plan that serves my district, was the first in the U.S. to have a dedicated integrated program designed to combat loneliness for its Medicare population called the Togetherness Program. And one of their patients, whom I shall call Susan, was in her 80s, was homebound, and experienced physical pain when doing light housework. She used a walker to get around and stated that this was a source of embarrassment for her, so she used that to avoid social interactions. So as part of the Togetherness Program, an employee with CareMore called her at least once a week to check in with her, have a conversation, and encouraged Susan to go outside to have exercise, even a short walk around the block. And as a result, Susan is now getting out and regularly attends social events. So I'd like to ask you, have you identified any barriers in the Medicare Advantage program that prevents plans from addressing mental health needs like loneliness as a part of a more holistic approach?
I would say it was a little harder in the past, but with the new flexibility that we talked about, where we can add these benefits to our plans, we're able to do things like exactly you said, offer community benefits to actually make our members feel like a part of the community, have social interaction. We also have our nurse practitioners who visit them in their home and can identify when they might need a little bit of extra help on the social side if they're being reclusive. And so definitely an area we're focused on, and I think in the future we'll be able to invest a lot more in that area.
And I would just say that I've read about CareMore's model, and we think it should be a model for the entire country that's really important and very successful. We're looking forward, again, to the flexibility that CMS is now granting us to address issues like loneliness. It's another social determinant that we feel very strongly about, and especially around mental health. So it is a focus of our plan, and again, the flexibility that we now have will allow us to do more in that space.
Thank you. Mr. Paulson?
Thank you, Mr. Chairman, also for holding the hearing today. There's pretty strong recognition that Medicare Advantage is improving patients' health based on the testimony we're hearing from you, based on the questions that are coming from all of us. It's using best practices in care delivery. It's the robust data analytics. It's proven value-based care and the care management models that are available through MA. And when you've got 1 out of every 3 Medicare beneficiaries that are utilizing Medicare Advantage, that tells you something. I represent a community certainly where I hear on a very regular basis from seniors in my community, please make sure we continue the Medicare Advantage program. That's a consistent message. And whatever we can do to help encourage more enrollment in a program that could lead to better health outcomes for our seniors and lowering healthcare costs is the direction we need to go, and this has been very helpful today. I know that the different health plans in particular have engaged in the marketing efforts that Representative Marchant had mentioned to help educate seniors about their options when you've got fee-for-service plans, Medicare Advantage, and then Part D drug benefit plans. And I know CMS also has used a marketing or a Part D program education effort to enhance their enrollees to 42 million plus by running an extensive national education campaign, you know, with mailings and flyers and television, et cetera, and advertising. I'm just curious, you know, Mr. Toy, Ms. Klausner, I'll start with you. Do you think that CMS could increase enrollment in MA programs by conducting a similar campaign? And if not, do you believe there is a better or more effective outreach solution to increase so we're more than 1 out of every 3?
So I think that paying attention to collaboration between CMS and the plans to increase education would be tremendous. I think CMS could focus on certain areas where Medicare Advantage enrollment penetration is lower than in other areas. So for instance, in Philadelphia, we have 40% enrollment penetration in Medicare Advantage, but there are certain pockets in Philadelphia where there is 10% penetration in Medicare Advantage, and I think it would be great if CMS and the plans could work together to figure out why is the penetration lower in certain pockets, in certain areas of the country where it's not at the 40%. Sometimes it's the number of plans that are available, but I do think you're correct in that it's also about education and not being afraid of managed care, which is a little bit of a holdover from history. But I think that would be great to collaborate with CMS on that from the plan's perspective.
I completely agree that we could do more with CMS, and I think that part of this is that, as we've been discussing today, there's a lot of innovation and flexibility that we can get through Medicare Advantage that traditionally the enrollees would not think of as coming from a health insurance plan, right? So because we don't look like health insurance plans anymore, the more sort of the traditional marketing methods try to sort of jam us into that box, and when really we're saying, hey, we're really going to look after you as a total life care experience, and that's very hard to get across when you're just saying, hey, no, how does this compare to just traditional fee-for-service? How does the co-pays compare? How do the premiums compare? We'd like to be compared on different axes and marketed on those those differentiators as well.
So, Mr. Holder, you talked a lot about the need to modernize the website, make it more user-friendly, 30 tabs opening up. I can only imagine how confusing that is for folks trying to navigate all that. My understanding is the Medicare Plan Finder is updated maybe once a quarter on the website. Other websites are updated on a daily basis, right? We know that. But maybe, Mr. Holder, you can comment a little bit more along those lines about how often CMS should be updating its website, as well as, are you aware of any specific audiences, be they rural or, race or ethnic or homebound seniors that are also need sufficient education where we need to penetrate that market?
Well, I think, you're raising good points. The the need to really understand and have a tool or a series of tools. I mean, the online plan finder may work for some audiences. For others, it may be the in-person assistance that can help them understand the differences for different choices. And I think a couple of things that I think would help. One is I talked a little bit in my testimony about sort of the potential for information overload. People see so many disparate choices, and they just say, I just don't want to deal with it. I'm just not going to make it. I'll just stay wherever I am. Now, maybe they're in an MA plan, maybe they're in traditional Medicare, but there may be a better option out there for them. And if they're in a situation where they just shut down and stop looking, that's not helpful. So I think anything we can do to sort of make the information clearer, cleaner, less of the sort of distractions of small differences would be helpful. Another thing that I think could potentially help, there was little discussion at the beginning about, sort of the role of supplemental insurance for traditional Medicare, the Medigap plans. And people that are in a Medigap plan with traditional Medicare, they go off and try Medicare Advantage, and then if they want to come back to traditional Medicare, they may not be able to get their Medigap plan back, or they may have to pay more for it. And to the extent that they understand that may actually deter them from trying out a Medicare Advantage plan. So while in a way it seems almost backwards, to help to provide more portability of Medigap coverage may actually help people explore the options of Medicare Advantage more readily. And so I think something where we can make sure that you can reacquire your Medigap plan after you've spent a time in Medicare Advantage. Right now you can do it if you stay just a very short time, sort of like oh, I didn't really mean to go there, I want to get back. But maybe you're in it for 2 or 3 years, and then the plan in your area changes and you're not so interested anymore, but now you can't go into Medigap. And if you think about that in the front, maybe you never tried that plan in the first place.
Thank you. Mr. Kelly.
Thank you, Mr. Chairman. Thanks for holding the hearing. And thank you all for being here. Because I think on both sides of the aisle, we're very, very concerned about this. Any program that has a cost of over $700 billion a year should be important to all of us. One of the main problems, I think, in Medicare Advantage is the benchmark cap, which was created under the Affordable Care Act, and many beneficiaries in my district, which, by the way, over 350,000 people participate in Medicare, are impacted by a misguided policy and do not receive the full benefits of being in a high-quality plan. Now, Mr. Kind and I have been working on a bill to eliminate the benchmark cap, and I think, Mr. Chairman, we'll continue to work on that. Another issue that I've been working on is the way CMS calculates Medicare Advantage rates. Currently, these rates include spending for beneficiaries with both Part A and Part B, as well as spending for folks with Part A only. This is comparing apples to oranges. And for seniors in the district I represent, they're getting shortchanged. So, Ms. Klausner, do you agree that CMS should be calculating rates based only on people who are eligible for Medicare Advantage? And how would this affect the beneficiaries?
I think we support rates being reflective of people who have Part A and Part B. I think what you're referring to is people who have Part A only.
Right.
I think we're seeing a change in the way that people access their Medicare when they retire. We're seeing people retire later, so they might not be picking up Part B. And I think people who have just Part A only and may have employer coverage on the B side, having 2 plans, are utilizing services differently. So we encourage rate setting at A and B level.
Yeah, I can tell you, when we do telephone town halls and when it comes down to Medicare, and we try to get this out, I just sit back and I listen to people for an hour and a half and how confusing it is for them to which direction they should be going in. So I just think, at some point we keep thinking if we just keep throwing more money at these things, it'll get better. So I think one of the things that we've been discussing are ways to improve the Medicare plan finder. I know in my life, I'm an automobile dealer. In a lot of the things that we do here, I compare to warranty work, and there's no one-size-fits-all. And I think that too often we tend to group everybody in there and say, well, no, this is the way it's going to work. And say, well, wait a minute. A person owning a car in the Northeast certainly has different conditions on that vehicle than somebody in the Southwest. Same car, two different environments. The same thing it is with people. So when you go to the plan finder, there's so many people in the private sector that right now do it well, and the reason they do it well is if they don't do it well, they go out of business. The government's answer to doing something poorly is to put more money into it from hardworking American taxpayers. Well, we're spending more money, so it must be getting better. I guess my question is, so why don't we just abandon something that is so new to the government? Again, I don't believe the government should be involved in getting this information out because they do such a lousy job with it. And I guess if it's not your money, you can spend it any way you want. But when it is your money, you have to be more careful. What your opinions? I mean, could this not be handled better as for navigating through people through these very difficult decisions? Anybody, because you all work on it, and I'd like to get your input on that.
So in my view, the advantage of having the government operate a tool like the Plan Finder is that you make sure it's an unbiased tool that doesn't tilt in any direction. You know, the concern that if different private vendors were to operate those kinds of tools is that they may not, you know, they may be operated by an organization that has a particular interest in where people land. And so I think it's keeping it as an unbiased tool that's the real advantage of having the government operate it.
Okay. Well, let me ask you, again, going back to my life, I couldn't imagine having howtobuyacar.gov telling people where they should go to buy their car. But I do think in the private sector, again, I'm going to what you all do every day. You know the pluses and the minuses. You know how difficult it is for people to navigate these things. I would stay as far away from the government as I could. An outfit that's $20 trillion in the red is going to tell me how to buy my health insurance or what's in the best interest? I mean, surely there's a better way to do this. And we see it in the private sector every day. We have people that know how to do this. So while there may be a bias, and you may be right, but I would say, depending on how you calculate who the money goes to in the end is probably more logical. So, I mean, Ms. Klausner, how do you feel about this? And the rest of you, you can just weigh in. We're running out of time, but I just know there's a lot better ways to do these things than to keep using taxpayer money.
I actually think, to the point I made earlier, that better collaboration between the health plans and CMS, I think the government position and the independence that the government can provide is important for beneficiaries. I think the health plans could educate CMS on what they're seeing in particular markets. I think different approaches for different markets would be important, but I think the main thing that I want to emphasize is the continued collaboration between CMS and health plans to serve beneficiaries.
Okay. Mr. Choi, you were going to?
I was going to very quickly say that one thing that you may think about is that when I talk to a lot of startups that are looking in this area where innovation can come, Medicare is not on the top of their minds just because of the age differences perhaps. And so having some incentives for innovation from that area might be something you could consider.
Ms. Mortensen, anything?
Sure. So I would just say right now we have one comprehensive source of perhaps difficult to comprehend information. I think if we left this to private sector or non-governmental organizations, you would then have 4 or 5 or 6 different organizations offering unbiased information that would be, you know, going back to measurement cacophony, even more information that would probably be even more difficult to process.
Okay. Thank you. I yield back.
Thank you. Well, the herd is thinning, but the faithful are still here. So thank you all for your testimony. Let me, kind of chairman's prerogative, let me just put together some of the themes that I've heard. Mr. Toy, you talked about, you know, intervention and using the data as a tool. Can you sort of thread together these other themes of social determinants and how it is that you at Clover use that information, if you do, to intervene and get better outcomes? How does that work?
Yes, absolutely. So the way to think about it is we sort of have the generating insights, and from our insights, we then activate interventions to actually make improve outcomes.
Okay, translate that for me. What does that mean?
So what that means is a lot of companies right now, when we're looking at data to actually find out, see something interesting that's happening out there, are only looking at one stream of saying clinical information, like looking at just your body and your health, or they're looking at just, say, financial. As payers, we often look at just claims data, and we're like, well, what do we see in the claims?
Are you getting other data? Is this like consumer data that's laying on top of this, and like all kinds of things?
So we can. So this is the area of the new frontier now. Traditionally, only these claims data or just maybe clinical data from the EMR is looked at. Now now we can also look at social data. We can look at these dynamics of that show signals towards maybe someone is homeless or maybe someone is not eating well. This data was not visible before in just claims data. We wouldn't know that from just your claims information. By blending all these together, this is now the time when we're able to actually make these get insights and say, well, you know what? Maybe this person's using a lot of care in this area because they're not eating well. And
so this is all, I want to open the aperture up a little bit wider, just so that I'm understanding. I'm trying to restate what you're saying to me. Let me see if I'm tracking. So you're saying there's new information that's available, and the new information is beyond claims data, and it's wider medical data. So is that right?
It's wider medical data and the social data on top of that as well. So
where's the social data coming from?
So the social data right now, because we're just being very careful how we look at this, is coming from sort of signals that we would get, for example, from notes. That's something that they would maybe mention to their provider. The provider would write it and say, well, this person has mentioned that they have difficulty finding housing, right? And then we'll say, okay, that's an important data point. We can extract that from the clinical note. Going forward, I think we'll start to see more and more use, of course, with the patient's permission, of like other social signals, like maybe their online social network and things like that. We're only just starting to scratch the surface in that particular
Pretty
area.
interesting. So I mean, and not being a data expert at all, but my sense is that there will be trends and patterns that are surprising, maybe even based on consumer habits that begin, and so that's sort of where it's going. Okay, that's helpful. Thank you. Ms. Mortensen, when you were talking about the tension between, when I practice law, there's substantive and procedural due process. Mr. Levin can relate to this. And what you were saying is, look, there's a lot of process that we're chasing around right now, and we're not really evaluating the substance. Is that a fair characterization?
Yes, that's right. So largely because these process measures are easy to measure, but they're also important to measure. Did you do this to the patient?
It's check
Did they
the
get
box
a flu
stuff.
shot, mammogram, colorectal screening, et cetera?
Okay, so shift it. If you were going to redesign, and you had just a clean palette, what would you shed and what would you embrace in terms of evaluation? And stipulate that people are willing, providers are willing and plans are willing to be evaluated, but they want the evaluations to be rational and to measure things that really matter. What would you propose that the ideal would be?
So the ratings shift each year, right? So as they top out, a lot of ratings are pulled out and additional ratings are put in, and you'll see some ratings are in for a year and out for a year. So there already is movement. So one thing is it might be nice.
Okay, just to restate that, just so I'm understanding it. What you're saying is if everybody's meeting the ratings, then they're kind of like not measuring anything?
Correct.
Anymore? So
then a new rating, a new largely process measure will come in, although some years process measures will be taken out and then maybe the next year put back in again.
Just to press the point a little bit, does that feel like the goalposts are moving?
So in Medicare Advantage star ratings, the goalposts are always moving, and the plans don't know the goalposts beforehand, and they're told maybe midway through what measures are going to be looked at, and what's a 3-star, what's a 3.5-star, what's a 4-star.
I get it.
So none of these guys know going in what's going to be measured and what the cutoff is going to be. Like I can tell my students an A is a 91 and above, right? They don't know what's a 3 or what's a 4.
A lot of pop quizzes here.
Exactly.
Okay. Okay, so then go back. I interrupted you. You were gonna say what's the process measurement that are de minimis and are not adding much value, and what are the what's your term of art? I forget it. It wasn't process.
More outcomes focused.
Outcomes.
Right.
Right. So that's your substance.
So I think this is challenging, right? And so there are commissions that have gotten together. So there's an international consortium on health outcomes measures by Porter and a few others at Harvard. So I think it's a great place to start looking at what are validated outcomes measures that are being used not in the United States only, but across the world. But also to tie back to focus groups with the Medicare beneficiaries. What is it you want to learn? And often what they want to learn are what are called patient-reported outcomes. So maybe step back, I hate to say this as a researcher, but step back from what's calculated in the claims data and allow these beneficiaries to respond on patient-reported outcomes or patient-reported outcome measures, which you actually see incorporated in the MIPS much more so than in the Medicare Advantage themselves. I think also metrics like healthy days that these insurers are already capturing Humana's doing the Healthy Days, and MedPAC has proposed the Healthy Days at Home metric, things that give the individual a better sense about what type of care can I expect to receive, but also this gives the plans an incentive to focus more on social determinants of health because they can point to these outcomes and say, hey, look, if we can get them more healthy days at home, however we do that, we're going to score better on our
Are healthy days at home, is that as intuitive as it sounds, like days that they're not getting care?
That's right. And so they had Ashish Jha, researchers at Harvard, say, show us what this, so MedPAC commissioned them, show us what this would look like. Show us how we measure it, what goes in, what goes out. So of course, Humana is going to measure it maybe differently than Harvard did, but you could agree on a metric where, and you could see if that's useful or not. But this may be one that health plans don't score well on, but it's still meaningful to the beneficiaries.
And the theory is if you measure it, you're going to get more of what you measure, basically.
Exactly.
Is there a plot trap in there kind of cooked into this storyline where health plans or others are being held to an account for things over which they have no control? So in other words, if I'm a patient and I'm getting all the good advice and I am acting with impunity, well, there's only so much that others can do for me. Is there a recognition in sort of this evaluation model that people still make choices and they can make bad choices too?
Yeah, I think that comment is very appropriate. Although you talk to the health plans, they'd like to see more outcomes-based measures, but we always know that there are things outside of the healthcare system that can affect that. But you'll see some of the measures in there will say, was the patient adherent to their therapy? And so that's not an outcome, but it's what you call an intermediate outcome because adherence to your therapy would prevent a downstream, even more significant event. So focusing more on those intermediate outcomes would be important as well. Was the patient adherent? Or looking at, so right now we look at, are there A1C blood levels under control for a diabetic patient? Why not look at average levels and compare that across time? So rather than just being sort of threshold, you could look at averages and compare those. Look for improvement across time as well.
Ms. Klausner, if head nodding is any indication of something to say, you have something to say.
Sorry, I was quite transparent, Ab. So I do think that there are a number of star rating measures that the plan can't control, like for instance, overall rating of the health plan with 40+ measurements. Many of them are under our control, but again, when a CAP survey, which is the survey that's sent to the beneficiaries, arrives in somebody's home and it's a paper survey and they're asking the overall rating of the health plan, you don't know what could have happened to somebody that day. Maybe they waited in their doctor's office for 2 hours, very likely, and all of a sudden they have a bad rating of the health plan, even though it was not something, obviously, that we could control. So there are measurements on there that I think are out of the plan's control. I think we'd like to work with CMS to figure out which ones are controllable by the plan truly and which are not.
Is there good work that's being done? Because some of that is that's life, right? So we're held to account for things over which we don't have control, and that's life. How do you, and I'm not trying to be cavalier about it, but how do you discern then, what's really those things that you do have control over? Is there good work that's being done on this, academic work and so forth?
I'll defer to Dr. Mortensen for the academic work. I think that you're right, though, that is just life, and I think health plans have taken that to be, it is what it is, and so we do control and work towards measurements that we can control. We try and educate beneficiaries. We try and educate them about the star rating system, and we accept it, but if we have an opportunity to make comments on things that we would like to see change, that would be one of them.
Okay. Mr. Toy, in part of your testimony, you were focusing in on barriers to entry. Just quickly, can you give a snapshot for what this arena is like when you're a new entrant in it, and what could we do that would lower barriers? Because by definition, that's a better thing, but we don't want to lower them so that it's just de minimis and there's no standard whatsoever. Where's the balance?
Yeah, well, I can let you know where we think the balance is. So where we enter a new market, like we're going into a new county, into a new state, then almost certainly there will be other plans in there. There'll be fee for service. There will definitely be probably some other MA plans already there. A lot of times the providers in that area will be consolidated. There'll be big groups. They may have very strong deals with existing MA plans already, and that may disincentivize them for wanting to contract with a new MA plan, especially one which by definition has low leverage because we don't have membership in that state. state because we're new. And so that is just like a very difficult cycle to break because we don't have membership, we can't get the providers, they don't want to contract with us yet because we don't have leverage, so they make it very, very expensive minimally. And so that's basically what it looks like. Our suggestion is that perhaps we say, everyone in Medicare should be treated effectively equally, whether you're on fee-for-service or whether you're on Medicare Advantage. And what that means is if providers are accepting fee-for-service, they should be accepting Medicare Advantage folks as well. They shouldn't be able to turn away Medicare Advantage people just because they chose a new plan that they might like, which is innovative. We'll negotiate in good faith. We can prove that we're doing that, but we want some balance there.
Okay. Let's see quickly, Mr. Kelly, you've got an article on Pathfinder.
Yes, Mr. Chairman, I'd like to submit this for the record. This is from The Hill on May the 4th, 2018, an article that is titled, Mr. President, Let Markets Help Save Medicare, and I'd like to submit that without objection.
Without objection, so ordered.
Thank you.
Ms. Mortensen, back to you. Just in terms of the measures and so forth, you mentioned, are there 44 or 45, and sort of, it seems an overwhelming number. Does it get to the point where the measurements are just, they have less and less meaning and they're taken less and less seriously?
Yeah, that's a good question. So there were 44 in 2017 and 45 in 2018.
We're listening.
And there are more than any other value-based program in the Medicare sort of array of programs. So they are pretty, overwhelming.
What's the difference between making an evaluation at a plan level and making it at a contract level?
That's a great question because most of the evaluation is done at the contract level. And academics like us argue that that really takes away from the meaning of what's going on with any given plan because everything is reported at the contract level.
You just get less insight and it's less discerning?
Sure, and it's more, I should be careful saying this, but there's more room for, it's a game for insurance companies now, because if you're a contract and you have low-performing plans, what you do then is you just sort of smoosh them into your high-performing plans, and now across the board, you have a very high-performing plan at the contract level, which was not the design of the incentive payments based off of the STAR quality metrics. There is some legislation in the Bipartisan Budget Act to address this, but I think that, and I should be kept...
To address the evaluation at a plan level?
To address what happens to the STAR ratings once plans are consolidated together. So it's meaningful in that over 20% of Medicare Advantage enrollees over the last few years have been put into consolidated plans. So what that means from the plan finder or the STAR rating perspective is me over here in Miami, I'm getting metrics that are reflecting plans that are sold in 4 different states. So it's not necessarily even meaningful for the beneficiary. So yes, most of this is happening at the contract level where it arguably should be happening, as MedPAC has proposed for many years, it should be happening at the geographic level that's most meaningful to the beneficiaries.
I get it. Mr. Toy and Ms. Klausner, lastly, can you just give us a little bit of insight into your experience with encounter data submissions?
Yeah, so with encounter data, we're already capturing most of the information that we require. Like, we're a very data-centric company. Like, we always capture data above and beyond claims, and the clinical matching between the actual claim data and the clinical data is probably slightly easier for us than most. So we were able to meet the encounter data deadlines ahead of time. We've been able to comply, but I recognize that that's not always an easy thing.
And I would say that for our plan, that we've seen improvements in the encounter data process over the last few years. It's much better than it was even a year ago, so we're pleased with that. I think there are still some outlier reports that come back to the plan that have errors, and I think we want those addressed before everything is finalized, but much improved over the last few years.
Okay, well, great. Look, on behalf of the whole subcommittee, we really appreciate your time today. You're people of incredible background, each of you. You gave us great insight and a lot of things for us to process. And I was teasing about members coming in and out, but they've really absorbed what you've got to say and have your written testimony as well. So on behalf of the whole subcommittee, we thank you for your time and your testimony, and the committee is adjourned.
Well done.